Okay, so who would like to start this week?
I can go anytime.
All right.
All right, let me show you. Let me actually just start with kind of not a case, but sort of a little bit of physics, not so much physics, but we have a new scanner. I just want to show you some interesting things, if you don't mind, seeing not so much a finding, but just a scan. So we have a new force, and it's our newest scanner, and we've just started scanning people on our force. So here is the CTPA on the force now. In the force, you have different scanning options, but suffice it to say, for this particular one, the actual scan time turns out to be sometimes quite a bit less than a second. So I don't know in this particular patient, but in looking at patients being scanned the other day, some of the patients getting a CTPA, the scan time that was on the console before the procedure was sometimes 0.48 seconds. So this may be an example where we're not even close to a second, but even below that. So here's a CTPA with a very short scan time. And you can see that we have great opacification of the pulmonary arteries. And then we can see that that is about it. So we barely have the contrast medium going through the pulmonary arteries. And there's just a little bit of contrast medium coming into one pulmonary vein here. There's a bit of asymmetry, I'm not sure why. But you can see that in this particular person, we just managed to opacify the pulmonary arteries before the scan was over. And it was diagnostic from that point of view, but there's really no contrast medium beyond just a little bit in the pulmonary vein. So we use a bolus tracking procedure. So we have a cursor on the pulmonary artery. We have a threshold of 100 Hounsfield units. And then our default until now for the other scanners we have is 6 seconds, I think it is. So when you have very little margin for error, if you then scan another patient, like this patient, which we had the other day too. So here I'll give you a little bit of background before I show you the CT. Here's a patient with, you can see here, he has a big heart, he's got lung edema. And let me just show you that in comparison with, let's see if I have a comparison. But you can see his heart is bigger now than it was in 2017. And you can see now that he has interstitial lung edema, he's got pleural fluid. So he's definitely got heart failure, left-sided. So that is on the 22nd, and here let me show you a CT done on the same day. And you can see here, using the same protocol, that we didn't even have enough time to really get through the pulmonary arteries completely even in the lower lung zones. So this contrast medium going through the heart, excellent opacification so far, but not so good when you get down here, particularly on the left side, where the scan is over before the contrast medium has even passed through these pulmonary arteries at all to get back to left atrium. So of course, since then, we've increased our delay time. We've gone to 9 seconds, but in this person with CHF, and I did have an ultrasound from last year, and I'm presuming his heart failure is worse now than it was here. But back then you can see he has poor ejection fraction and what was described as reduced right ventricular systolic function, that being back in last year. So this is just a pitfall. So we've learned from this that we're scanning so fast now that we really have to adapt the protocol. And of course, if you have a person with CHF, well, then you're even more trouble in trying to get the timing right. So I think this scan also was probably like a half a second or so.
So Howard, one of the things we do, we don't have one of those scanners, but we do our timing off the left atrium.
Yeah, you see, you could do that too. You could just
that way we know with our contrast injection and all that, we know that if there's contrast in the left atrium, assuming there's no weird shunt. There's contrast in the pulmonary arteries as well. And
Yes.
the other advantage is it lets us see the aorta, the left
Right.
and the left heart chambers very well. So we've picked up aortic dissections, we've picked up
Right.
other things. Thrombus.
Yeah, that's definitely what one can do. I think here, because our techs are so used to doing it a certain way and putting a cursor in the pulmonary artery, if we can change our protocol so that we can simply increase the delay time and then get adequate opacification of left-sided structures, that'll work too.
Yep.
And all they have to do is change the delay time once on their protocol on this scanner, and then if we have success, we'll be fine without going to the left atrium. So we've seen some really fast scans. I really like these scans. You know, when you do get a scan like this, the vessels are very crisp. And the problem of pulsation artifact, for example, even in this patient, if you look at the vessels,
thrombus in the SVC there next to that catheter too.
see if that is the case. Can't remember. I think that might have been. I don't remember. You think it's, let me see, right there maybe?
Looks like it.
Maybe that's a thrombus there. He's got,
Yeah,
he's also,
Yeah, it's a gorgeous scan. And I agree with Jeff. I've been trying to retrain our techs to target off the left. I mean, I'm trying to go away from this idea of doing a PE study anyway. It should be really, in essence, a double rule out in every case where you look at the aorta and you can go left ventricle as well.
Yeah. So that's definitely an option too, is to go over the left so you make sure that we opacify the left side so we can look for pathology there. But yeah, exactly. But in general, I really like the scanner. It's so fast that we have almost no motion and sharpness from breathing or even cardiac pulsation.
Is it timed to the cardiac cycle to try to do this?
No, I have to explore that. In other words, they have the so-called flash mode and the turbo flash mode. But for the flash mode, which is the dual source scanner, I'm trying to remember whether you can actually start the scanning in relation to, for example, a portion of the cardiac cycle. I think you can, but I haven't gotten that far yet to do that as well.
And how big is the detector in this thing? Is it 30 centimeters long or something like that? It must be an area detector.
Yeah. So this is a detector that has 96 detectors compared to the 64. We just have Siemens equipment. So we've gone from multi-detector 64 to 96. But I can tell you for a scan like this that the table speed, the feed in, is 48.5 centimeters a second. That's quick. And you can actually go to what they call turbo flash, which is like 73 or so centimeters per second table feed. That's really quick.
I think that's two Gs. So
that's really quick.
Right.
Yeah. So another thing I've learned with this new scanner we have, which is the dual source, is that there is something called a pitch-dependent scan field of view. So sometimes if you want to really get the fast turbo flash, you can't necessarily scan and include the entire patient. In other words, the scan field of view is less. It's not a problem for the heart only because the scan field of view is small for the heart. But if you're scanning a big patient, you may not be able to get that speed and scan the whole patient. So it's sort of a pitch-dependent scan field of view. But even without what's called the turbo flash, I mean, yes, it's really fast. I mean, this is only half a second, about half a second or so, even at this speed, between half a second and a second. Yeah. All right, let me show you an interesting case we had the other day. So this is an unfortunate young person with sickle cell disease, and he's pretty ill. He's got a lot of things going on. He's got pericardial disease, but he also has central venous obstruction. And as far as I know, I've got some of my residents here, the central venous obstruction has been ascribed to central venous thrombosis from catheters. And he actually has a stenting now in the SVC. And the stent that he has, as you can see, goes quite high. So it covers where the left brachiocephalic vein would come into the SVC. So he's got central venous obstructions and he's got a stent. And of course, we see all the collateral pathways that we will see in a patient with central vein obstruction. Particularly the superficials, we have, I won't show you all of them because we've all seen these before, but the ones I want to really show you today, which is really interesting, are the collateral pathways that go from systemic veins to the left atrium. So we've all shown quite a few cases of shunting from perihilar mediastinal veins to the left atrium, but we also know that you can shunt from chest wall veins to pulmonary veins to left atrium. So look at this over here. When we have a look at the scan, we get down about here into the inferior pulmonary vein. We can see it's quite bright here in the left lower lung, and he's got pleural fluid. Now take a look at all these veins traversing the pleural space. So right over here, and as I scroll down, you'll see the vessels actually are opacified, traversing the pleural space to the lung. So it's a pretty dramatic demonstration of the vessels that can form, connecting up the chest wall vessels to the pulmonary veins and into the atrium. And he's got a lot of periphrenic collaterals as well. But I don't think I've seen this phenomenon before, perhaps because we don't usually have an effusion, but you can see all the veins traversing the pleural space.
So they're going through that big rind of pleural effusion. That must be chronically organized effusion to have all those vessels stretched across it like that.
My resident says he didn't have the pleural fluid a little while ago.
Really?
Well, I think that he just has these, well, he's had time to make collaterals between chest wall veins and the lung. I think we just have a great opportunity to see them traversing the pleural space because now he's got pleural fluid.
It strikes me that they're awfully stretched to do that with that lung collapse like that away from the chest wall.
Yeah, yeah, yeah. Yeah, this is the most dramatic example I've seen of that. I think they just reflect the chronicity of the venous obstruction, right, in part. Look at these crazy things. Look at the one right there. Going right through the pleural space into the lung. And then these veins down here are relatively bright with contrast medium, having been fed by all these vessels here. Right there. So a pretty dramatic demonstration of that particular pathway.
Wow.
This one is kind of interesting. It's kind of a bit of anatomy. So the clinical context here is a patient with chronic renal failure, and he is known to have secondary hypoparathyroidism, and he's had that for a while. And we don't usually see the parathyroids on CT, so here we go. So I was thinking the anatomy we see is a little bit odd. So that's the anatomy of parathyroids. And take a look at this person's parathyroid. So here we go towards the lower poles of the thyroid, and you'll see we have 1, 2, 3, and 4. 1, 2, 3, 4 parathyroids. And it's interesting that they project sort of inferior to the thyroid lobes, whereas usually the superior ones are a little bit higher than the inferior ones. So I am pretty certain that we are seeing these parathyroids. And it's kind of interesting where they are. And we can see all 4 of them. Do you guys recall a case like that before, seeing parathyroids with hypoparathyroidism, all 4 of them?
Never seen them. Just ectopic parathyroid adenomas in the mediastinum.
Yeah. So these are all 4, but they're all 4 a little bit big. Sorry, not showing you the right place. This goes back to 20. 15. And we'll, yeah, they're a little bit low. Let's see if you had those before. It's like 1, 2, 3 up there. There's another one right there. But they're a little bit low, right?
You think it's just that they're big and that's why they become visible? Because they're really plump?
Yeah, they're definitely big. I think these are ordinarily, aren't they, just like 5-6 millimeter structures? Small guys. Mm-hmm. And this one over here particularly is quite big. This is the biggest of the 4 that we see here, the other ones. So that's really just curious. But we see all 4 parathyroids being big.
It's just hyperplasia.
Yeah, hyperplasia. Yeah, hyperparathyroidism, hyperplasia, presumably. Yep. All right. Just a quick case of something we've all seen before, and that is this here. So the tip-off over here, this is actually a bit hard because the history was initially confusing, but you can see he's had embolization procedures, presumably for hemoptysis. I wasn't really sure of the history. But then on conventional chest radiography, if you're lucky enough and you see these cystic structures here, you can see round, thin-walled cystic structures in both lungs. And then in relation to one of them right here, there is a little demi-lune of fluid in the dependent portion of one of those cystic spaces, but he's got lots of cystic spaces. And then again, if you look at his, whoops, not that. If we look at his trachea, it's a little hard to evaluate there, but on the lateral projection, this is his big trachea. And as you might guess, this is very consistent with Meunier-Kuhn syndrome, with the bronchiectasis. The tracheobronchomegaly, really big bronchi, some contained fluid, but really classic features for Meunier-Kuhn syndrome. And I just assume, I don't know for sure, but I assume he's had episodes of hemoptysis requiring embolization. All right, those are my cases, Jeff.
All right, we'll let Travis go because he said he might have to dash out in a minute. Let's see, where is it? There we go.
Do you see a Rankinogram?
Yes.
Yep.
All right. So some interesting stuff's coming in the last week. This is from yesterday here at the VA. And this is a patient who came in, and this is not a gunshot or some sort of birdshot. This is actually a pain marker. So he came in with right-sided pain, and he does have a couple of rib fractures I'll show you on the subsequent CT, and there's a little lucency here. It's kind of vague, or sorry, not lucency, but a little subtle opacity, which corresponds to small little hematomas. But I think probably everybody, the first thing you looked at was, or first thing that caught people's eye was this odd thing on the left. And you can see that looks like there's an air fluid level here, and then there's this more just vague amorphous opacity that doesn't really have borders. I'm going to show you the lateral now, and check out this thing. Pretty cool. You can instantly see that it's in, or probably most likely in the fissure. And I think a lot of this explains why we see it the way it is on the PA view, just because it's the idea of this incomplete border sign. When it's in the fissure, you just don't see any, there's no real interface here in this big ovoid, pill-shaped thing with a big air fluid level in it. So he underwent a subsequent CT, and I'm curious, I have my theory on what this thing is, because he definitely had trauma, and the history was that he had had a little bit of hemoptysis the last couple days. So his story with the rib fractures on the right, and you see these little hematomas right here, these look like they're still fairly acute. He fell about 10 days ago, hit his right side, and had been bedbound since then, did not seek medical care until he started having hemoptysis. So his injury on the right side was 10 days ago, and he had so much pain on the right that he just stayed in bed. Then he started having hemoptysis. But I think that, and maybe you guys will agree, this just looks like a big hematoma that's sitting in the fissure. So it's a pseudotumor in the fissure. And I am guessing that somehow it communicated with an airway, which is why he has this ground glass and a little bit of stuff in the airways here. Just it is probably just hemorrhage and hemoptysis. So I don't know. Maybe up north here, there's a little communication with some of his paraseptal emphysema. But had one of my colleagues dig up an old study, and you can see this was a few months ago that he had an old healed rib fracture at that time on the left side, and clearly nothing there. So this is an acute thing, but I think it must just be a hematoma, that's resolving and somehow developed a fistula, which is why he now has air in it as well. Anybody have comments? I think it's pretty cool. What happened to that?
Must be, if it wasn't there.
Any other ideas?
So you think that the hematoma is in the fissure?
I think so. I think it is. I mean, that's what it looks like. That's what it looks like here, don't you think?
Yeah,
Travis.
it's in the fissure.
What'd you say, Jeff?
I agree with you. It's plural.
It's
Yeah.
intravenous.
So how about this, Travis? Suppose he had a pre-existing adhesion from his old trauma, and he just developed a loculated hemopneumothorax.
Yeah. He let's see. Here's the report.
Or there's history and things happening that we just don't know about, that no one knows about.
Well, yeah, he said that he had denied trauma to the left side after they saw this, but he said he did strain his left chest a couple of months ago. So I guess maybe it's just an old, asynchronous injury that happened before that just happened to start to resolve and ended up in an airway somewhere and started draining. But
that's really weird. No, there's no hint of a stab wound or something to the chest. I know there's no history of that. No,
there's nothing, and there's no acute fractures on the left side either. Just this old one back here. But I just thought it's really cool, just because the radiograph, especially, it's a good teaching radiograph just for the incomplete border sign with something that's either budding the pleura or rising in the pleura. Plus, you've got this air fluid level. Yeah. So
very cool. Yeah.
I like Jeff's idea about a sort of a contre-coup tear on that side. So I think he fell on his right side. He tore something on the left, and he bled into the pleura there, and was contained in the fissure, and then sort of seeped into lung from there, or lies into lung.
Yeah.
I think that's quite cool.
Yeah, I think we're all on the same page. There's trauma that happened at some point in time. Yeah, I like the contre-coup idea. That would tie it all together nicely.
I think it's layers of trauma. Former left trauma, and now trauma. Yeah.
All right, here's a fun case that I think you guys will like. This is a guy who's in his 30s, history of asthma, came to an outside hospital last month. And you can see there's a lot of volume loss on the left side, and there's a left effusion. Plus, there's just a big hole, another air fluid level. Looks like it's in the left lower lobe on this study, and you can see a nice air fluid level here. The fluid, just generalized volume loss. I'll show you this was all done at an outside hospital. And then, of course, this was just read as a necrotizing pneumonia in his left lower lobe, which certainly is just big air fluid level. And I think most of this is an abscess. Some of it may be pleural as well. I think that's a different story. But if you look at the rest of his lungs, you see that he has very abnormal substrate really everywhere. These are, unfortunately, the thinnest images we have. But he has a lot of bronchial wall thickening, a lot of mosaic attenuation throughout, and these areas where you have lucent lung, really smaller vessels in those areas, and it affects both lungs. A lot of bronchial wall thickening, but just notice here, it really looks like an obliterative or constrictive bronchiolitis, in some of these areas. So I've got a lot of studies here. He spent a long time at the other hospital, and then he came to one of our infectious disease specialists last week in follow-up after he'd gone to surgery, had a decortication, and they were basically referring him for evaluation of what antibiotics to put him on. And when I saw this, I instantly was thinking that there's something chronic going on here. he'd had a history, quote, of asthma, but to me this looked more like a Swire-James type of picture with all of these areas where he has what looks like obliterative bronchiolitis and a lot of bronchial wall thickening. And so she went and talked to him. He had a history of asthma, but then on further reporting per the ID note, this was her addendum, that he knows recurrent pneumonia during childhood. And I guess, I don't know if he specifically said adenovirus or if she asked him or whatever, but I think that kind of ties this all together. Unfortunately, we never did expiratory images, but looks like a pretty good example, I think, of a Swire-James or post-infectious obliterative bronchiolitis. And also one of these ones, I know David's shown cases, just a reminder that it's not a unilateral process in most cases. They can be bilateral.
I'm a little doubtful of the adenovirus just because I'm thinking that long ago, I don't think PCR was widespread.
That's probably true, yeah. But the childhood infections would certainly, lead to that, and maybe, and then the question is, does he really have asthma, or is this all just related to prior infection?
Yeah, well,
so,
I mean, if it's reversible, then it would be. Yeah, it should. I mean, he should have had, what the bronchodilator challenge and all that.
Yeah.
Probably doesn't have conventional asthma though.
No.
Travis, do you think that he might have had an immune deficiency, though, that caused all those childhood infections? I mean, maybe they were recurrent bacterial infections.
That's a very good question, too. I don't know. Yeah, if he had some sort of IgA or hypogammaglobulinemia or something, yeah. I think they're going to work him up further. But it's certainly not just asthma.
Right.
So, yeah, I think with, this bronchial wall thickening and the bronchiectasis, certainly he deserves more evaluation.
Definitely. Good idea.
All right, this one came in yesterday, and we are going to start with a head CT. It's a guy who's, I don't know, around maybe 40 years old. I'll have to look and see here in a second, but altered mental status. He has a long-standing history of a seizure disorder, but recently has had fever. He's been a little bit more altered, went to an outside hospital, had a head CT and then a brain MR that looked much like this. This was the repeat one here. And you can see on the right, there's a subdural fluid collection. You can see how the gyri are displaced inward. And then on the left, he has this this low attenuation thing with some surrounding vasogenic edema. And so as happens here, and you can see how the cortical veins are displaced by this fluid, by the fluid there on the right. So as happens at our place and probably all of yours, whenever there's something like this was said to be likely a mass. So he was sent here for evaluation for suspected either primary mass or metastatic disease. And so he got the routine chest, abdomen, and pelvis to look for either primary or metastatic disease. And in the meantime, our neuroradiologists were looking at this and re-reviewing the outside MR and thought it looked more like an abscess. And they had and a subdural empyema on the right. And in the meantime, they did this study. He does not have a cancer, but of course, what he does have, though, is this big arteriovenous malformation in his right middle lobe. And so I think you can see it drains into his right middle lobe pulmonary vein here, and it was arising from the right middle lobe artery right here. So no cancer, unexpected finding there, and I'll show you. He has a smaller arteriovenous malformation in his left upper lobe, and so of course that kind of seals the deal that this is going to be an abscess. Patients essentially from paradoxical embolus, and they took him to the OR last night, evacuated this, and they got just frank pus from the abscess and the subdural empyema, and not surprisingly, that this is growing polymicrobial bacteria, and these may be enteric or whatever, but the idea is that they just bypass the lungs through that AVM and then end up with systemic emboli in the brain. So I don't know if you guys remember, I showed a case a few years ago of a patient with hepatopulmonary syndrome, so not a one AVM but multiple AVMs that presented with a brain abscess from a GI source. Now we don't know exactly what these were, but I did find this paper talking about HHT, and I don't know, he might have HHT since he has at least two AVMs, But they were just talking about when you do see cerebral abscesses in these patients, that most of the time that they may be anaerobic germs, they may be strep. So this may be a strep with paired gram-positive cocci, but also polymicrobial abscesses in a lot of these patients as well. So I just thought it was a cool case that we can kind of explain everything. And just a reminder, whenever you have, emboli, be it bland or septic or infected emboli or abscesses in the brain, that certainly AVMs can be a cause of this. So I'll include this nice little review article. It just talks about just the breakdown of all of these things. So I'll stop there, Jeff.
All right. David?
Got a couple. So is a radiograph visible?
Yep.
This fellow had pretty clear lungs at this point in late December. He's had shoulder prosthesis. He's had some rib trauma on the left. And then he started coughing up blood. Let's see if I can advance here. And he presented with this radiograph. At the time he was having hemoptysis, so he got this patch on the left and a smaller patch here on the right. On CT, we have this ground glass abnormality. It's got some sharp margination over part of its boundary, but not all. It's got a little reticulation superimposed, so a nice crazy paving pattern. And this was a pulmonary hemorrhage. And so there was a whole lot of serology done. All of his ANCA studies were negative, things like that. He was coughing up a fair amount of blood, but he got better. And sort of in mid-February, you can see that his radiograph has cleared to some degree. And then he came back just day before yesterday with new round of hemoptysis, and this is on no treatment. And now he's got much more consolidation, particularly on the right, but it's moved around the left base, so a recurrent hemoptysis in this person. And he got quite an extensive workup. He had a surgical lung biopsy, and the pathologist is saying that this is a pulmonary capillaritis, and he has no evidence of vasculitis elsewhere, and it's there are no serologies that are abnormal, so they're calling this an isolated posse-immune pulmonary capillaritis or capillaritis if you're from the other side of the Atlantic. So this is what our chief resident in medicine presented in showing this case to medicine residents a few days ago. I think this is a very nice little table here about causes of pulmonary hemorrhage, which is now, these days, everybody calls this diffuse alveolar hemorrhage. In my experience, that was really a specific consideration in people who had stem cell transplants, particularly allo transplants. But now that term diffuse alveolar hemorrhage is being applied to any sort of widespread pulmonary hemorrhage. So here are different kinds of capillaritis here, or capillaritis, systemic vasculitides and stuff like that. He's got no indication of or serologies for any of these things. And so this is now being called an idiopathic or a isolated pulmonary capillaritis. Kidneys are okay. No other organ system. Skin is okay. There's been a skin biopsy, and that was okay. So no evidence of vasculitis elsewhere. So the treatment for this, it's evidently a fairly rare condition to have something isolated to the pulmonary system like this. The treatment is big doses of corticosteroids, and then sometimes I think rituximab is added to that. I think that's the agent. So isolated pulmonary capillaritis, got to practice that, okay. And then here's the case that I showed roughly a year ago, a man in his young 50s with this very swollen looking aorta here, and he had a dramatic CT scan that showed tremendous aortitis here, gross thickening of the wall of the aorta, and it tapers off as you get down into the abdomen. He's got a lot of lymphadenopathy, and it's very well defined mediastinal lymphadenopathy. It really looks like sarcoid pattern of lymphadenopathy. I did find a case report of sarcoid-induced aortitis, and that's what I thought the best candidate was to explain both the lymphadenopathy here and this aortitis in this guy. So he had a long workup here over months, and nothing really fit very well. One of the consideration was Cogan syndrome, which I hadn't heard of before, which involves eyes and ears, and it's a kind of rheumatologic condition, and then can also have an aortitis. That was one of the considerations. Let me show you his PET CT scan. This is the SUV version to show you the dramatic uptake of the metabolic agent here in the aortic wall and in the mediastinal and hilar lymph nodes here. That's pretty much it. So eventually,
David, it looked like the coronaries were involved too. At least when you scroll through quickly, the right coronary artery
on the CT.
Yeah.
That's a very good point, because clinically he has coronary artery involvement.
And I think as you were scrolling through, the right coronary just looked like it had circumferential soft tissue thickening.
Circumflex.
Even the circumflex too, but yeah, look at the RCA there.
Yes.
And it was more in the mid portion as you were scrolling down where it looked like that as well. Yeah, yes. Right there.
So definitely not normal. And eventually had a renal biopsy, and he had a node biopsied in his groin, and they both disclosed IgG4 disease. So this turns out to be, and they only made this diagnosis last month after, I think, more than a year of IgG4 related aortitis, which I had not heard of. And I think he's got some kidney involvement with that. So he's got some renal disease going with that. And he had it in his lymph node in his groin as well. So I didn't see on the list of aortitides IgG4 disease. I've not seen this in my limited experience with this disease. Have you guys seen anything like this before?
No, David, but your timing is perfect, because one of the invited speakers at the STR meeting is going to talk about IgG4 disease.
Is that the guy from MGH?
Yeah, Jay Ryo.
We've shown a couple of cases. I know I've shown one, and then Seth showed more of a periaortitis, but they looked indistinguishable from Takayasu, not this degree of involvement, no lymphadenopathy and no coronary involvement.
Mm-hmm. So there you go.
Wow. If we scroll down, can we look for anything related to, well, kidneys? Sometimes get renal involvement, occasionally involving coronary.
And symptomatically, he does have renal involvement, and that's he did have an abnormal biopsy.
And he's got no extrapleural tissue related to mediastinum, pleural surfaces up higher. I didn't see any.
No, I was hoping for Erdheim-Chester with this or something like that too, but I never saw anything in those funny locations. He doesn't have retroperitoneal fibrosis here. He didn't have pancreatitis, and wow. I think his liver was okay. So, so mystery solved. I mean, we have a diagnosis finally in this case after some 15 months, I think. I think I posted this case before, but I didn't have the bone scan, so I'll repost these studies.
So if he's lucky, he should respond to, I think it's methylprednisolone is the first steroid they try.
Okay.
Oh, that's pretty dramatic. Wow.
Okay, guys, for the case I wanted to show.
Thank you. All righty, let's see here. Speaking of aortas, why don't we look at this one? So this was a 68-year-old guy who was driving himself to a medical appointment and at high speed and rear-ended a semi-tractor, whatever you call it, tractor trailer. Was in a pretty bad wreck, and you can see his chest radiograph. The lungs look pretty good, but the upper mediastinum is abnormal. There's too much soft tissue up in here, and these all get CT'd anyway. Sometimes they've already gotten the CT by the time the radiograph is available. So we see a couple of things here. First, there's blood in the upper mediastinum. You'll notice it goes all the way back to where the spine is, and it's sort of separated from the arch vessels by some fat. But as we go further down, we'll see that there is actually thickening of the arch wall, but it maintains separation from the rest of the spine because of this fat plane. And then further down, you can see indeed there is intramural hematoma, and I'll change the window, and you can see there's a pseudoaneurysm right at the isthmus where we'd expect the ligament, which is right there to be. So classic location of a traumatic injury. But what's interesting about this case, I went back through all the ones we've shared and the ones I've had, and only found one other one that had that wasn't quite this extensive of an intramural hematoma that tracks all the way down, and it went way into the belly. And he's got stranding in the mesenteric fat. He's got chronic pancreatitis. He's a chronic renal failure patient, hence the kidneys aren't really lighting up very much. So he did have some bleeding in there as well. They did explore his abdomen, but you can see it goes all the way just about to the bifurcation, maybe a little bit higher. So traumatic aortic injury. So there is that classification system from the Society of Vascular Surgery that was based on a paper published from Harborview, I think back in 2012. And we've talked about the minimal aortic injury. So they talk about an intimal tear, and then there's a large intimal flap if it's more than 10 millimeters, or if there's a thrombus. This would qualify as a pseudoaneurysm. And I think all the mediastinal hematoma is part of it. He did have some spine fracture right here. So I think that's all related. And I think this is all contained. But one thing that's not addressed is there what they do with an intramural hematoma? But they ended up stenting him. He went straight to the OR. They stented this, and then they explored his abdomen and repaired some minor lacerations. But I thought it was kind of cool, just this extensive one.
So Jeff, you think that the hematoma that was paraspinal up higher was coming from his spine and not from this vascular injury?
Yes, and what I can gather from the endovascular operative note, there was no extravasation when they injected their contrast, because there's this fat plane that persists throughout the whole scan, separating it from. Because usually when you have, if you had an mediastinal hematoma, we'd expect a lot more blood. And it's right where his fractures, and it doesn't track down or anywhere else. And all the other ones I've seen with extravasation fill the mediastinum pretty intensely.
Right. Because
there's really no tamponade effect at that point.
Very dramatic.
Okay, this is a cute little case of, so this is a guy who presented with a fever, cough, clinical diagnosis of infectious pneumonia. You can see he's got an old smoking history. This is chronic. He's got this cavity up here, this bronchiectasis, some calcium in it. I don't know if it's old TB or not, but he presented also with hemoptysis. It was not just a little bit of blood tinted sputum, but he'd cough up a tablespoon or two every so often. You can see there's debris in the airway. And pooling in the left lower lobe is all this consolidation. What's kind of interesting is it almost makes a fluid level. So maybe a lot of secretions and pus filling emphysematous spaces, debris in the airways. Yeah, and you can see there's some what looks like cavitation, because this is too well defined, I think, to be just a bolus space, and particularly this irregularity here. So some sort of necrotizing infection. And the reason he has hemoptysis is all the way right, is this little guy right here, which this is, I can't think if this is our study, but we got an outside one as well that showed this little bitty area right here, sitting right on the diaphragm, right above the diaphragm. So it's presumably a little pseudoaneurysm, and you can follow it back to these little branch pulmonary arteries. I'm presuming that's what it's coming from. And so the management for this is just treat his infection and hope this thing will scar down and not require any other intervention. As of yesterday, he was still having a little hemoptysis, but it seems to be waning. So I'm guessing it's starting to heal.
But Jeff, let me turn this upside down. Could there be a pseudoaneurysm that has bled, and the consolidation you're seeing is blood, which is settling?
It could be, but since it was progressing over a scan, yet his hemoptysis, it's possible, and some of it might be, but there's a clinical infection, fever, leukocytosis, and some of it, I don't know. There may be some blood in there, but he's not having that much hemoptysis, I think, to account for all this. And it persisted over multiple studies. I don't expect it to change or kind of wax and wane.
Okay.
But yeah, it's a good thought. So this is, yeah, they're not always from TB. We've seen a couple with staph and strep. All right, this is I mentioned this last week, and this is just a good case when you're talking about lung rads. This was a lung cancer screen baseline, and there's some weird cystic stuff in the apice. I think that's just funny, emphysema. I don't know what to do with these nodules. I don't know if it's smoking related, a little LCH in there or something. But this part solid, part cystic, part ground glass, part cystic nodule was identified. And if you look at lung rads, there's no category of what to do with these. I mean, you could measure it as a large ground glass nodule, in which case it would be a 3 based on bigger than 20 millimeters. But it has a cystic component. And we all know when we see the cystic component, the likelihood this is an adenocarcinoma is really high. And they also, when you have air bronchograms, we know that. So this was called a 4X, and that's the X factor is, of course, features that make the radiologist more suspicious that it's a cancer. I don't think anyone would doubt this is a cancer, but it's interesting they don't address this in lung rads, but they took it out, I think appropriately so. And what's interesting is the path. Let's see if I can pull it up here. So it's an adenocarcinoma, but it has a micropapillary component, which is, if you look in the literature, is associated with a far more aggressive course, very poorly differentiated. So even though we have what looks like these indolent ground glass cancers, when they have a cystic space in them, I think you have to be a little bit more cautious about I mean, you can watch them and see how they behave, but that these can move a little bit faster and transform. And you can see already that this thing was a T2, I don't have the stage, but it was bigger than a T1A. So it was a T1B, so it was a little bit higher stage, just purely based on size. So this is one I would be worried would be a lot more ugly looking a year from now. I'm not sure I'd even sit on it for 6 months, but interesting.
If you scroll through the rest of the scan, are there other areas that you worry about for multifocal lesions, ground glass here and
not
there?
Particularly, yeah, and that's something we see a lot. Not particularly in this case. I think the stuff up top was more inflammatory. There may be one here, but that one's pure ground glass, and he's got these more irregular looking things that don't have the typical morphology. This more looks to me like smoking related lung disease, but we'll have to wait and see when he gets his follow-ups.
Yeah, 2 points. I'm glad you said.
Go ahead.
I was going to say, I'm glad you called it a 4X, because we had one very similar yesterday. The solid component was a little bit bigger. The amount of cystic stuff was smaller, but it was still a mixed lesion that doesn't really fall into any good category. Because if you only measure the solid component, it was going to be like a centimeter, but I called it a 4X.
Right.
Because it's similar to that. And then we were talking about it last week, I think, with the micropapillary. Yeah, this person has, unfortunately, a bad prognosis. I wouldn't be surprised if they come back with metastatic disease.
I mean, it was predominantly acinar, but there was a micropapillary component, which is interesting. So, yeah, the 4X is an interesting topic, and there was a really nice study that was published from the Netherlands where they looked at the NLST data, and they had 6 chest radiologists go back and score certain cancers from there, and what the conclusion was is if the radiologist called it 4X, it almost always was cancer, and the one that wasn't looked like cancer anyway. So it's sort of that undefined entity, the gestalt or gut or whatever you want to call it. But it's what we all know that's hard to put into a classification system. But I think one that may get more attention as we get more data from registries and stuff. But every 4X, we've had about 3 of them, and every one was a cancer. Not surprising. Okay, this last case it's a twofer, and it's just great teaching case. And this patient was transferred to us in such condition, and they repeated a radiograph here just to make sure all the support apparatuses were in expected location. And you can see this central line here has an odd course, and the point I like to make is when a subclavian central venous catheter really should be subclavian, and clearly this is not. Also, it's more medially oriented and overlies the aorta. These are some outside radiographs. You can see how far down it was at a different institution. So it was not recognized. That was when he originally presented. I don't remember what his initial history was. But you can see that this was unrecognized at the time and packaged up and sent to us. And then they did do a CT. There wasn't really any question, I don't think, about it, but they did a CT anyway. It may have been for other reasons, but you can see there's the line in the subclavian artery going down. But from an anatomic standpoint, here's a contrasted study. Older one was I want the coronals here, just to see where the subclavian artery is I'm going to come more anterior, is going to run. So it's on a radiograph, it's going to tend to project over the clavicle. The arms are up here, whereas the subclavian vein will run, which is more inferior, will run under it. Now, what's cool about this case is also the other finding. There was this little funny nodule here, and so we said get some old imaging, deal with this later. We don't know what it is. But then we did get some old imaging, and on the CT, we can see, if you look on the left, there's all these dense nodules or high attenuation. They may be enhancing along the pleural surface here, and it's very unilateral. And if you haven't figured out where I'm going with this yet, you'll notice there's some old rib fractures down here, and then we get into the belly, and Mr. Spleen is not there, so this is just a nice example of splenosis, pleural splenosis, and that was confirmed eventually on an old abdominal CT that showed the same findings. Yeah, here's the non-con from here. And this is typical of it to be high attenuation. So it does enhance like spleen, but it also is naturally high attenuation because of the high density of cells. So arterial line and some splenosis for fun.
Wow. Cool.
All right.
Excellent.
Nice
Thank
case.
you.
All right. Well, we should all be back on Thursday after STR, so we'll continue next week.
See you guys.
All right. Bye.